welcome everyone, and we appreciate that we are the only thing now standing between you and the drinks downstairs. So we really appreciate your continued attention for this session. So I'm really, really honored to be in this conversation today with Kevin and Tiara. And before we get kicked off with the questions, I'm going to let them introduce themselves. So Tiara, if you want to go first.
Sure. My name is Tiara Green, and I'm the interim CEO for Accessia Health. Accessia Health is a national nonprofit organization that provides financial assistance to individuals with rare and chronic conditions.
And I am Kevin Hagan, the president and CEO of the PAN Foundation, and we are a national patient assistance charitable foundation and advocacy organization.
Great. Now, I know we've got some questions to get kicked off with, but for full transparency, I'm here on the rare disease side of things. So for me, patient assistance programs is a really new concept. So I'm sure you guys all know what this is, but for my benefit, could one of you maybe just give us a really quick description of what it is that you're both trying to do?
Go for it.
I'll start. Our goal is really to lighten the burden for patients with rare and chronic conditions. And I should take that back because I've been really intentional about not saying patients because they're people first. But we help individuals with rare and chronic conditions afford their health care. We've heard a lot during these last few days about the difficulties in being able to access care, and that's just one bit of it. So our goal overall is to ensure that they have the access, ensure that they're educated on ways to access their care, and really considering social determinants of health as well, and making sure that they find their voice to advocate for themselves.
Great. Anything to add, Kevin?
I would concur with absolutely all of that. And the one thing I would say is that, depending on the patient assistance program that you're looking at in terms of the independent charitable foundations, we do a variety of things. We cover medication copays, but we also cover things that address those social determinants of health, like transportation. Some of us offer premium assistance. So if health insurance is a better way for you, we will support the premium cost for that. So I think there's a variety of opportunities in terms of patient support and access that we offer.
Great, thank you very much.
Yeah.
So what are some of the misconceptions and misunderstandings about charitable foundations like yours in what you offer? And to both of you, whoever wants to go first.
Take it, I'll take it.
Go for it.
Just to expand on what Kevin was saying, one of the misconceptions is that we only focus on that copay assistance for the medication. Yeah. And it extends, like Kevin said, into health insurance premiums and travel. We also assist with medical expenses. So thinking about, in order to get a treatment plan, I have to actually see my physician, right? Mm-hmm. And for many, that means that I have an out-of-pocket cost that I may not be able to afford. Yeah. So we step in and we help with the cost of those copays, and maybe there's lab testing that is necessary or durable medical equipment that is necessary. Those are things that we help with as well. In addition to that, if I think about the number of people who need assistance, many people think that when we have a wait list, we are not assisting anyone. It just means that we are helping those that are currently receiving assistance, and that as a charitable organization, we could use more donations so that we can assist more people. There is no shortage of individuals who actually need our assistance, unfortunately.
And I would also add that I think one of the misconceptions is, the way that all of us operate is we have disease-specific funds, and a patient can apply to that fund. And I think one of the misconceptions is that if a fund is closed, that's a terrible thing. And that's not necessarily a terrible thing. And I think that's a piece of the narrative that I would like to correct. I mean, of course, would we like the fund to stay open year-round? Absolutely. And with donations, we can make that happen. I mean, if the donations are coming in to support that fund, it can stay open year-round. But a closed fund just means that we met the patient need as quickly as possible. I will encounter donors from time to time. They'll say, well, we gave you donations, but the fund only stayed open for 5 days. I mean, particularly when you look at PAN, If you look at third-party research that has been done about patient reach and scope, we have the largest among the charitable foundations because of our history and longevity. So what that means is that we're able to reach patients very quickly and enroll people. But that's a good thing. That means people are having their chronic diseases managed faster. It means people are on therapeutics faster. It means people with life-threatening illnesses are getting treated faster. So I think that's a misconception that I would like to change, is that, you know, a fund that closes quickly is a bad thing. It means that we got patients on therapeutics really quickly. And I think that's one thing in general our sector of the charitable foundations are very good at as a whole. I think we're good at getting money out the door into the hands of patients.
And just as a follow-up to that then, what are the challenges for you both in communicating those misconceptions? You know, you said these are some of the things you'd really like to address, but how difficult is it for you to get the word out there? And I guess what support do you need in able to address these misconceptions more broadly and more wider within the community?
I think just being here, right? Having these constant conversations about who we are as an organization and who we serve and how we do it.
Yeah.
It helps, word of mouth. Everyone in here could take this back and tell someone else about this, but we also put out newsletters. We're all on social media. We try to constantly communicate so that others are aware of our functions and how we do business.
Yeah. And I would just add that, you know, we operate, not every charitable copay foundation operates a wait list, but we operate wait lists because it has been indicated by the OIG to be a best practice. So we operate these wait lists, and I think that's a telltale sign in terms of continued patient need, and I think that's something that we should be doing a better job talking about, and I think an opportunity like this presents itself where we can talk about it. That, you know, if we have a wait list, that means there are people that are waiting to get on therapeutics right now. And with further assistance, we can make that happen.
Great. Thank you. So I'm going to read this one out just because it's a long question and I don't want to get it wrong. So how has the initial implementation of the Medicare Part D reforms impact how you approach your programs and the need you see from patients, and how might that need shift as the full reforms go into effect?
It's a good question. I'm going to read some stats. 336 million are the number of individuals in this country, right? 38 million of those live in poverty. And if we think about Medicare Part D, there are over 10 million households that are led by someone over the age of 65 that is considered cost burden. So when we think about how has this impacted our programs, they still need our assistance, right? We heard in the session yesterday, Corey did a fantastic job about talking about the IRA. And he talked about, we really don't know what's going to happen, right? There could be a increase in our health insurance premium costs. We can see narrowing of formularies. We as an organization want to be there for those individuals, and honestly, people are still knocking at the door saying they need financial assistance.
Absolutely. And I would say further, just in terms of statistics, when the IRA passed, the team can tell you, the first thing I said is, okay, we need to understand what this means for patients from the long term. So we commissioned some research right away with Avalier. And one of the pieces that we learned from that research is that, you know, when they looked at all the Medicare data and looked at the reforms that were going into effect, is that there will still be 2.6 million Americans who will reach the cap in 2025, which means that they will spend $2,000 a year just on medication costs. So that's 2.6 million people that are going to hit that. There are 800,000 people this year that will spend 10% of their annual income just on medication. So when you think about that, that's just the cost of the medication. That's not the copays. It's not the diagnostics. It's not the total cost of care. It's not rent. It's not, childcare. So there's this whole picture that I think we as collectively as an industry need to begin to grasp and tackle, is that does a $2,000 cap help? Absolutely. Is it something we all wanted and advocated for on behalf of patients? Absolutely. Is it going to solve all the problems? No. Because, as Tiara alluded to, we're already starting to see what the ramifications and the unintended consequences, as Corey mentioned on day one, are going to be. I mean, Pan, we shared with you earlier session our State of Patient Access report out of our new Center for Patient Research, and we just did a rapid poll, particularly around insurance premiums. And I literally just got the information today before coming in here, and 28% of the people that we've polled said their premiums have increased. And I believe it was 20% of those, they increased more than 10%. And then if you compare that with an Avalere study that came out in October that showed a 21% increase in premiums for standalone prescription plans, I mean, you're starting to see some of those consequences. We're also anticipating more restrictive utilization management. All of this, I think, leaves not just the charitable copay side, but all of you in the PAP world in a little bit of flux too. And I think we're all just trying to see what is the industry, and I don't mean industry like our industry, but what is the market response from an insurer and payer perspective to manufacturers, to the government, to charitable side. And I think that sort of anxiety that exists in the system now is really preventing all of us from having a strong path forward, I would say.
Right. I think you brought up a really good point. We think about the average Medicare household has an income of $45,000, right? They use half of that on just housing. So you're left with $1,600 a month to afford your health care. Health insurance premiums are $174.70. We shouldn't know these numbers like this, but Medicare Part B premium is $174.70. That's about $2,100 a year. And we're saying $2,000 should be nothing, it should be easy, and we're not thinking about the full scope of all the things that they have to pay for.
Yeah.
Sure. Now, I've got one more question before I'm going to come to the audience, so I'm giving the audience a one-question warning that you're going to need to come up with your questions pretty quickly. So kind of following on from that, some of those really stark statistics, how are you addressing the continued disparities in health literacy and health equity? It's obviously a huge issue, and you've pointed it out with all those statistics, but how do organizations like you start to tackle that, or continue to tackle, I should say?
Sure. Accessia Health has a webinar series, Amplify Your Voice, Control Your Care, in which our goal is really to ensure that we are empowering those that we serve with information to make informed healthcare decisions. I'll say that health literacy is two-pronged, right? I think about this, and I'll get off my soapbox after this. But I went into the doctor's office and I gave them my insurance card, and she said, "You have Medicaid, right?" She didn't look at my card. She looked at me and said, "You have Medicaid," okay? Second example, I am helping my mother manage my grandmother's care. And I'm on the phone and I'm listening because I'm just listening in to make sure I'm guiding the conversation. The physician gets on the phone and says, patient comes in with acute CHF, CMP 2000 panel, looks great. And I said, hold on. We talk about health literacy. It's not only what we're doing to educate the patients, but it's the providers as well. And that we have to ensure that we are educating the providers to talk in layman's terms so that these individuals can understand their health care. So yes, we are working on our side to make sure that we are educating them and equipping them with the information to understand their health insurance, to speak up for themselves, to know how to speak with their physician and empower them, but it's a two-sided thing. So as an organization, our goal is really to empower patients, but also figure out how we can work with the medical community on cultural competency, number one, and number two, on how to properly speak with patients so they understand their care.
And how difficult is that challenge? Because as we know, reaching and educating healthcare providers who've, you know, they're limited time and limited resource,
Yes.
and many of them are in burnout and, you know, in difficult phases of their, you know, careers for healthcare providers. How difficult is that to try and address
It is
at that
difficult.
grassroots level?
It is really difficult. One of our health equity projects is working within one zip code in Kentucky. It's in Louisville, Kentucky, and we are a partner amongst many other organizations. It's a hospital system, it's a university, AARP, and all of these different organizations who play a different part in the puzzle for social determinants of health. So when we look at that model, it allows us to speak with those physicians who are in that network to say, this is the problem, right? The key piece here and in that community group is that we are also working with faith-based organizations. We're going to where the people are and we're saying, let's meet them there and then meet their needs as well in helping them navigate, because that's their trusted resource. So that's our way of educating the medical community. We use community health workers, we're using faith-based organizations, and we're saying these are their fears. We're listening to their voice and then communicating back.
And Kevin?
And I would say, specifically on the health equity side, I mean, we have been focused on disparities and, you know, trying to figure out the best way to tackle these things. So, like, one of the first things that I want to ensure is that our grant portfolio, the funds that we do for, you know, individuals in need, actually reflects the population of the disease state. So we're monitoring data pretty closely around that, because, you know, if a disease state is more prevalent in one community of color, you know, is that reflected in the way we're giving out our grants as well? I mean, we are required on a first come, first served basis under our advisory opinion, but I think there are ways that we can better market and better promote to communities of color and people who are in areas where there are health disparities. And it's not just communities of color, it can also be rural versus urban. So we're looking at a variety of things. So that's one area. We have also done some work around education, particularly around providers. We did a sponsored series, a donor-sponsored provider education series around health equity and working with different populations. So we did a session on rural, we did one on mental health, we did one on different communities of color. To try to better educate providers. And then one of the things that we have piloted just to try to see how it worked is we actually worked with some blood centers in zip codes that were predominantly Hispanic and African American to bolster enrollment in our hemophilia funds. And we did see some early signs of success with that. That pilot is just concluding. So we're beginning to look at ways that we can more proactively engage those communities. But I would also agree that a lot of it has to be done through partnerships. So we have at PAN begun building partnerships, particularly with a lot of the provider organizations like the National Medical Association, which is the predominantly African American medical association, the Hispanic nurses, and a variety of medical associations to provide some support and education in that process as well.
Great, thank you. So you were all warned, so hopefully someone has a question for our esteemed panel. Any questions out there? And ask me anything, panel people, come on.
That means we did a great job with answering
sure
all of your
did.
questions.
All right.
Oh, we got
excellent.
two, all right.
There we go.
Hi. I have one question for you. It's really just, I think, from the billing side of it. You know, I'm in specialty pharmacy, and right now we utilize your grants for specific medications. We know that when we sign a patient up for a grant, it's based on diagnosis, and then within that diagnosis, you have essentially your own formulary of drug that you'll, you know, help with a copay on. right now in our pharmacy systems, we plug it in as a, as a secondary insurance, BIN, IDPC, PCN, and everything. How is that going to change if in 2025 we have patients that are signing up for this, copay smoothing program? We're so used to that, copay assistance being linked to that specific drug. But when we're looking at them signing up for this copay smoothing, they're looking at all of their drugs across the board. How is that billing going to change for us? And the patient, is it going to be more responsible for the patient to submit, reimbursement forms if they have an active grant with either of your programs?
It's a really good question. I think that's to be determined, right? We're not sure what the smoothing program will look like and how it will impact our processing of claims, but it's something that we will be sure to communicate as soon as we know.
And we have a whole lot of very smart people working on that.
That's right.
Was there another question?
Yes, hi. Along those lines, this year, there are patients who had a grant from last year that kicked in, let's say, in April of 2023, and they're not eligible for another grant, or they were approved, but it's not available until April of this year. Are those patients, if they were to pay their $3,300 earlier in the year, are they able to reimburse themselves once the grant kicks in?
Is that a question for
Well,
Pam?
I'm trying to, give me the example one more time. So it's
Sure.
April.
Sorry, it's a lot of numbers. So essentially, patients at the beginning of 2024, if they're on an expensive drug, they paid that $3,300 for their copay up front in January, since there's no smoothing this year. But if they're not re-eligible for a grant until later in the year, because I think it's on an annual basis,
Right, yeah.
then are they able to reimburse themselves if they paid the $3,300 in January?
So if they paid the $3,300 in January and they have a grant, we do have a direct member reimbursement process that they can request reimbursement for.
Oh, good, and it would come back to them.
Yeah.
Oh, great, thank you.
Any more questions? Okay. I shall break out my emergency questions then. So, what role do charitable foundations play in advocating for policy changes? So obviously this is quite topical with these new reforms coming in, but the policy changes that benefit patients in need, and what other healthcare access issues are concerning you from a policy perspective?
Loaded question.
Sorry.
No, it's okay. I think we play a critical role in that we are educating policymakers on the impact of some of these policies on those with rare and chronic conditions, but we're also educating those that we serve on what's coming. I hear a lot about the Medicare Part D reform, and all I imagine is someone that is elderly not knowing that smoothing is even an option, what that means, how do I sign up? It's confusing, and we're talking about it being an opt-in kind of process, right? So when we think about advocating for policy changes, yes, we're advocating for this policy change, but we're also educating our patients on how this may impact them. When I think about that question of what's concerning you, that's what's concerning me from a policy perspective is how are these individuals going to understand that, number one. And number two, if we think about the Help Copays Act, which we've heard a lot about over these past few days, the reinforcement and how do we ensure that every state, right, is looking at the Help Copays Act and ensuring that those copays are counting towards the out-of-pocket maximum.
And I would just add that I think our role as charitable foundations can be really critical in advocacy and advancing policy, because I think we sit in a unique position in the ecosystem where we see patients across disease states. You know, in my prior life, I was the CEO of the American Diabetes Association. So I knew deeply about one disease state and could represent the patients in that disease state. The problem is people with diabetes often have other comorbidities. So I think the charitable foundation like PAN and Accessia, because we cover 70 disease states, we get a unique view across a variety of diseases that most patient advocacy organizations don't have. And I think that makes us a unique player in the ecosystem, particularly when it comes to advocacy and what makes sense for good policies. And I will embarrass her, but I'm going to shout out Amy Niles in the back of the room, who is our Chief Mission Officer. This whole concept of smoothing originated by a paper with Dr. Jalpa Doshi from the University of Pennsylvania that was submitted a decade ago in what we call the PAN Challenge, which was to look at what options existed to make healthcare more affordable. And over 10 years, that paper won the PAN Challenge, by the way. Over 10 years, that has been worked through patient advocacy community and ultimately made it into the IRA. So I think that's a classic example of how a charitable foundation like ours was able to do something that a lot of people think will make a massive difference in the lives of people being able to smooth. Now, it's going to be a complicated process. We didn't want it to be complicated, but you know, it's the government and regulations are involved. So, but we're going to do our best, to Tiara's point. So I think we play a huge role in advocacy and can play even a bigger role in advocacy as we move forward.
And in terms of these changes that are coming, we know that anything that's related to policy never moves quickly. Do you have any understanding at this stage how quickly this will be implemented? When you do know what it looks like, how quickly will then that be implemented? And from a UK citizen who's very ignorant of the way it works here, from a state-to-state perspective, will that go out across the board, or will each state then have to implement that separately? Like, what are the parameters for this actually starting to work and roll out and benefit patients?
I think when it comes to the Part D reform, that's nationwide, right? It's a national initiative, and as nonprofit organizations, we just have to act quickly on our end to make sure that we are educating those that we serve.
And we are actively working with CMS. I mean, we are providing them our thoughts on ways to implement this from a better perspective, particularly around the Medicare prescription payment plan, which is smoothing, is what it used to be called. So I think we're really focused on that. And I think just in general, sort of going back to your question around advocacy, as these policies get implemented, I think we play an important role because of that unique perspective across the disease states, that we can provide really good insight about what patients are actually experiencing. And we've heard a lot of talk about alternate funding programs, and like, this is an area that we're very concerned about, just like almost everybody in this room is. And we have people sitting on the federal task force that's advising the government on, like, what is this really doing to patients, and really trying to figure out better ways to help patients ultimately live a happy and healthy life.
Any more questions? Yeah.
I have a question. First of all, thank you so much, Kevin and Tiara, both for all that you do for the communities that you serve. It's just a real privilege to see all of the work every day that both of you do, and we appreciate you and your teams. One of the questions that I have is it seems like there's a pretty big gap, I'll call it, between premium assistance offered versus copayment assistance offered on the charitable side. In some disease states offering that, some not. Some funds are really well funded, some are just not at all funded on the premium side. And one of the arguments that we continue to make seems to be that, obviously supplying the drug is absolutely essential. That's what we're all here for. And at the same time, if they don't have the insurance to begin with to be able to have the drug to be able to make that happen, obviously there can be a big gap. And so does that seem to be a gap that's widening from your vantage point, or do you think that gap is kind of evening out? Is it getting better? Is it easier? Because it seems like some people participate and some people don't. And I don't know, it seems like that there's a wide variety there that among a lot of different disease states. If you could speak to that, that'd be great.
Absolutely. I'll take that one first, in that our programs, we launched Your Assistance, Your Choice last year. So let's say that one of the programs has a $10,000 assistance amount. We allow the individual to utilize the assistance on anything that suits their needs. So if the program offers, and most of our programs, 99% of our programs offer copay assistance, premium assistance, medical expenses, and travel. The caveat to that is that only $500 may be used for travel, but they can use the remaining $9,500 or the full $10,000 on all of those others, because we understand that some may need the premium assistance, some may need copay, but you also have that mix of individuals who needs assistance with their out-of-pocket costs to pay for their physician copays.
And I would just add that this is a topic that comes up, and it just came up recently in internal discussions. And I think this is an area that we continue to look at and monitor. And we'll probably, over the course of this next year, just candidly have our own internal discussions around what grant design looks like, very similar to Accessia, particularly given what we are beginning to see happening in the industry. I think as charitable patient assistance groups, we have to figure out how to best serve the individuals we're trying to help. And you know, I shared some data early on. Premiums are going up 21% according to Avalier, and you know, we may see shifts in the market that dictate us being more flexible in our grant administration.
I think, I don't know if we've got time for one more question, Ali?
One more.
Is there anyone else in the room, or? So I have a final question then for you guys. It kind of leads on from this, but are there any particular challenges with rare disease patients and families? And have you been involved in any innovative solutions and programs that have been a real success story?
I think most of what we're doing is really for those who have rare conditions. Most of our programs are rare. Some of them are on the chronic disease side. But when I think about innovative approaches and success stories, it's really going back to those community-based approaches where we're able to tailor our communications and our outreach. If you've heard me speak once, you've heard me say our zip code has become more important than our genetic code, because depending on where I live, I may not have access to certain treatment centers. If there is a hereditary angioedema center that is in California and I'm all the way over here, how do I get there, right? So it's bridging those gaps and making sure that individuals receive the care that they need.
And I would say our grant portfolio is mixed. You know, we definitely do cover many rare diseases and provide premium assistance for some of those as well. I would say one of the key things that we have really tried to do, particularly as a charitable foundation, is, you know, making sure that those individuals are connected with other resources. So we have an alliance partner network, which are disease-specific organizations. We have nearly 30 of those in our network now, where we actually effectively give a grant to that organization to help provide further support services to those patients. So, you know, I think that's one of the things that's worked well for us, since we are able to provide a limited number of resources through our grant program, but having those alliance partners that can provide further support, and then we can support those.
Thank you.
And they really have the expertise in the rare disease.
Yeah. Yeah.
So actually, it's not a question, but Kevin, you know me. I'm Michael. I'm a huge PAN advocate, and I'm very passionate about everything I do in DC. And I think you hit the nail on the head that you are in a unique spot. You know, those organizations that are out there like PAN are in a unique spot to move things and move that needle. And you know, I do a whole lot of research on advocacy and the efforts, and it does work. It really does work. So if you guys in the room have never been to an advocacy meeting or anything, there's used statistics out there now that says if you're a congressman or senator, doesn't have a clue about the bill, you got to remember they have hundreds of bills that come across their desk every single day. But if you bring your attention to a particular bill that can improve healthcare, 94% of the time, now mind you, it has to be bipartisan. Let's just put that in there right now. If it's bipartisan, 94% of the time they'll sign on. So the voices from the patients do make a huge difference. And the more you can do that, Kevin and crew, the better off we'll all be.
That's right.
We're out of time, so we will let you all head downstairs for a drink. Thank you very much for joining us and for your great questions and for your attentions. And if you can just join me in thanking Tiara and Kevin, that'd be great. Thank you.